Well, good morning, and I'm really delighted to have the opportunity to engage with you here today to, in fact, talk about what I consider to be the heart of the matter, which is the patient experience of care, and how that experience, when it is both valued and validated, can actually influence healthcare improvement in all aspects of healthcare: policy making, standard setting, research, regulation, clinical practice, but most importantly in education, providing the opportunity to bring about that thing which we almost want, sustainable culture change, through engaging with the new cohort of healthcare professionals. All of that can really be only effectively accommodated in a structure which ensures that we learn from the raison d'etre of healthcare. And what is the raison d'etre? It is the actual man in the bed, the patient, and also come to a very real understanding of what constitutes truly patient-centred care. And events such as this, if you like, afford us the very real opportunity to engage in some reflective learning around some critical issues. Things like leadership, the kind of leadership we want and need. And it has been said what distinguishes leaders from managers is that managers help people see themselves as they are, while leaders help people see themselves better than they are. Partnership. And it is now generally accepted that patients, healthcare professionals, policymakers, and healthcare workers should all be working together. Medication safety, which has been designated by WHO as the third global patient safety challenge. And then frontline staffs, often described as heroes on the front line. I have met countless frontline staffs who, for example, want to do the right thing in the aftermath of an adverse event, but they are fearful of putting their heads above the parapet. They ask the question, and this question was actually put to me at a conference in Copenhagen a number of years ago. Do you, Margaret, want us to give information to patients which they can then use against us? And I certainly think that there is something very toxic about both a mindset and a corporate mindset which causes that kind of anxiety. That current reality has in fact spawned the patient advocate, people such as myself. As WHO patient safety champions, we're not career advocates. We are volunteers who are committed to being collaborative partners and co-producers of safe healthcare. Circumstances have brought us to this work. We've not chosen it for ourselves. Rather, it is a responsibility which has been thrust upon us, one which we would very gladly relinquish for the restoration of the lives and the well-being of our nearest and dearest who have been harmed by healthcare, albeit unintentionally. We strive to have these experiences become catalysts for change in an improved health service. We do accept that we cannot change the past, but what we can do is we can use that past to inform the present, and then in the present we can influence the future. And isn't it so much better if we do that together in partnership, a partnership which can be summarized as a process of empowerment of patients and families by enablers within the system. And our patient role in that partnership is, I think, best articulated in the London Declaration, which was an output of our first workshop held back in 2004 when the UK had presidency of the EU. And it says things like, we Patients for Patient Safety will be the voice for all people, but especially those who are now unheard. And again, in honour of those who've died, those who've been left disabled, our loved ones today, we will strive for excellence so that all people receiving healthcare are as safe as possible, as soon as possible. That is our pledge of partnership. It's our patient pledge of partnership, and it is most certainly my Margaret Murphy pledge of partnership. The preferred commitment from healthcare says we will proactively engage patients in their own care. We will capture in every way possible the lessons to be learned from the care experience of the raison d'etre of healthcare. And over and above that, We will embed patient and family into every aspect of our organisation's activities. We can then deliver a framework such as that described in the report of the Irish Commission on Patient Safety and Quality Assurance, which says knowledgeable patients receiving safe and effective care from skilled professionals in appropriate environments and with assessed outcomes. Michael Leonard, physician leader for patient safety at Kaiser Permanente, he offers this very simple definition of a culture of safety, which says, no one is ever hesitant to speak up regarding the well-being of a patient, and everyone has a high degree of confidence that their concern will be heard respectfully and acted upon. When making the case for engagement, we're supported as well by the report 2006 Safety First, which says that around the world, healthcare organisations that are most successful in improving patient safety are those that encourage close cooperation with patients and families. It's also interesting to consider the results of a recent survey conducted by the Irish Medical Council, and I sit as a lay member on that Medical Council, and this survey examined public opinion in relation to the different professionals. And the respondents, over 90% of them said they trusted their doctors to tell the truth. Now, I wasn't at all surprised by that result, because after all, you are the people who hold our lives in your hands, and you are the people who we patients certainly want to hold in high regard. And isn't it all the more unacceptable when such a high level of trust can sometimes be betrayed? That takes us to the matter of disclosure. The trustworthiness of systems and individuals is most severely tested in the aftermath of an adverse event. And if you like, in how disclosure, transparency and open communication are played out. And I'm convinced that disclosure is not about blame. It's not about apportioning blame. It's not about accepting blame. It is actually about integrity and about being truly professional. It is about learning and preventing recurrence. And as a consequence, a burning question for me becomes, why do essentially decent and professional people sometimes behave in a very inhumane way in the aftermath of an adverse event? And perhaps that is an area for simulation in the conduct of the disclosure exercise. And of course, there will be challenges. I have heard Jim Conway, Senior Vice President of IHI, describe that kind of push-pull dynamic of the engagement process as making the status quo uncomfortable while making the future attractive. Sentiments echoed by Lucian Leap in 2008 when he said, "The time is now. If health and our healthcare are at the table, then the patient, the family member must be at the table, and they must be at every table now." And that calls on healthcare to embrace patient engagement and involvement, and it calls on advocates to have the courage to challenge. And I like to think of us as being a little bit like the piece of grit in the oyster, causing sufficient irritation to bring about the pearl. And in this instance, the pearl can be that of healthcare improvement. And some time ago, I was invited to sit on a high-level committee in Northern Ireland, and I really loved one sentence in the invitation letter. It said, "Margaret, we want you to be a critical friend." And I think that is a fabulous role for patients and advocates to have. There are those who might ask, why would highly trained professionals listen to patients and advocates? And in response, I offer you the Indian proverb which says, "Tell me a fact and I'll learn. Tell me a truth and I'll believe. Tell me a story and it will live in my heart forever." And patients like Mike Evans certainly have very powerful stories to tell. The most effective tool we patients have is to tell our stories. And why? Because our stories evoke feelings. Back in 1967, Vera Keane wrote in the Bulletin of Nurse Midwifery, "Facts do not change feelings, and feelings are what influence behaviour. The accuracy, the clarity with which we absorb information has little effect on us. It's how we feel about that information that determines whether we will use it or not." And I remember again, not so very long ago, leaving a conference in London, and a Welsh doctor shared the lift with me. And as he was exiting, he said, "I'm taking a lot home, Margaret." And he pointed first to his head and then to his heart. And you need the two things. Similarly, I was speaking in the British Medical Association building to young doctors, agents of change, and I wandered around the building. I was curious about the venue, and I saw their sigillum. Around their sigillum were the words "with head, with heart, with hand." So you do need the three elements. You need the intellect, you need the heart, and you do need the skill. So maybe it's time for me to invite you to come on a journey with me, the journey of Kevin's patient journey, in fact. Simple measures save lives. Simple measures were not taken and Kevin lost his life. In fact, I would say every point of contact failed him. And in particular, his case history clearly illustrates that in the case of the acutely ill patient, there is very often quite a long antecedent period during which successful intervention is possible. And for Kevin, that period spanned over almost 2 years, but no one did take advantage of that precious time. So I offer you the ultimate official data in relation to Kevin. It's his death certificate. It lists multi-organ failure, hypercalcemia, parathyroid tumour. People do not usually die from primary hyperparathyroidism, especially when blood tests revealed high levels of calcium almost 2 years before his death. Adverse events happen to real people. Kevin was more than a statistic. He was more than a medical condition. He was a young man full of life, attending college, you would say, with his whole life before him. He certainly knew how to push all his mother's buttons. He could make me laugh, he could make me cry, he could make me proud of him, he could make me disappointed in him. But more than anything else, he was my beautiful boy, handsome, strong and carefree. Kevin was admitted to hospital a mere 8 days after this picture was taken. He had spent the summer in the United States on his J1 visa and returned early to attend his sister's graduation. 3 days following that admission, she and I sat at his bedside in ICU. Kevin had died right before our eyes. Nothing or no one had prepared us for this. We had questions, we needed answers. No one had intimated that his life was in danger. They were very simple questions. What went wrong? Why did he die? We need to know and we need to understand. How can a young man go to hospital on Thursday and be dead on Sunday? Please explain that to us. What we encountered was closing ranks, lame excuses, muddying of the waters, and protestations of loyalty to colleagues. So disappointed and frustrated, we retraced Kevin's medical history over the previous 3 years. This we did without any support. It was a difficult exercise. It was hard to ask the questions. Very often it was even more difficult to hear some of the answers. And the story slowly and painfully unfolded. The failings and shortcomings were many in number, they were serious in nature, they were indicative of system breakdown, and that was compounded by misdiagnosis, inappropriate treatment and management, together with issues of communication and data handling. And as you engage with his journey, I ask you to consider how laboratory results were mishandled, how those results provided sufficient data which, if interpreted correctly and acted upon promptly, would most certainly have saved his life. And in fact, the potential to achieve proper diagnosis and treatment was, I would say, sabotaged. It was sabotaged by a combination of filtering of test results and that very serious inaction. And those errors did range from his treatment at primary care level right through to that afforded him in a tertiary training hospital. And that's why I say every point of contact failed him. And what was that unfolding story? 2 years before his death, he presented on a number of occasions with persistent back pain, lethargy, mood swings, inability to concentrate, quite fractious. His personality changed. And in effect, he was a textbook example of primary hyperparathyroidism, in that he had the moans, the bones, and the groans. The only bit that was missing was the stones. Without any improvement, in the autumn of that year, he was referred to an orthopaedic consultant, and blood tests revealed high levels of calcium at 3.51 in a normal, very narrow range, as you know, of 2.05 to 2.75. As you can see, the plasma creatinine level was also very much off kilter and already indicated a more than 50% loss of overall renal function. And all of those abnormal results were highlighted in the laboratory report. But when writing to the GP, the consultant really underplayed the high calcium levels, didn't make a referral, but just made a reference to the fact that were they to remain high, he would like to see him again early in the new year, but never actually gave the numbers, nor did he forward the hard copy of the laboratory results. Now, that letter is not in the GP file. We know it was written, we don't know if it was posted, we don't know if it was received, but what we certainly know is that no action ensued. And as a result, that consultant's intention to see Kevin again was never conveyed to the patient. It's also significant that throughout his care, only one set of clinical eyes saw those test results. At no point was the hard copy forwarded, and neither did it travel with Kevin himself as part of a patient-held record. And I'd be a great advocate of a patient-held record. I would agree that we wouldn't be able to interpret results, but we would certainly be aware of changes, and that could stimulate questions from us, which in turn might actually also stimulate the necessary action. The opportunity to initiate best practice, if you like, was thwarted. It was thwarted firstly by not recognising the seriousness of his condition. Secondly, the absence of a system to flag the high calcium readings in a way that would cause the referral. And then not communicating the test results in their entirety, and thus depriving the patient from that second pair of eyes. Kevin's file contains a notation by the doctor's secretary, and I'll read it for you. Telephone call from patient's mother. She's extremely worried about her son. She wishes you to know that she thinks he may be depressed also. Failed his first year exams, repeating and not doing well either, finding it hard to study. He's now remaining in bed a lot. She has arranged an appointment with Dr. X's psychiatrist tomorrow and would like to have the result of blood test bone scan for the consultation. Now you might ask, why in heaven's name are they taking this young man to see a psychiatrist? Purely because we had tried everything else. We were grasping at straws. She wonders if he really has a back problem. What can I tell the mother? She wished to speak to you. Results on file. And the doctor's response, fax results to Dr. X. There was no direct contact with the mother, and neither was there direct contact with the patient. Carers and family members are often dismissed as being over-anxious, and I would say that you ignore at your peril the concerns of a mother. I assure you that umbilical cord is never totally severed. I was speaking to students in the RCSI yesterday in Dublin, and they laughed when I said that to them, and I said, you know, you'll never get away from us, you know, and that is the fact of the matter. The patient and family are critical components to the integrated care process, and my understanding is that one of the aims of that pathway is to improve clinician and patient communication and patient satisfaction. And sadly, the patient is often the piece in that jigsaw which is missing. Kevin was on each occasion returned to us as seemingly healthy without explanation for his sometimes unacceptable and erratic behaviour, and it was only later that we learned that that was caused by his undiagnosed medical condition and the fact that while his bones were softening, including the bones in his brain, the viscosity of his blood was being altered and putting a huge strain on his heart. When adjudicating on the quality of Kevin's care, Peer reviewers later said things like the combination of bone pain, renal failure and hypercalcemia in a young patient points either to a diagnosis of primary hyperparathyroidism or metastatic malignancy, and this ominous result should have been investigated as a matter of urgency. All the evidence indicates that the patient was suffering from a solitary parathyroid adenoma at the time. Removal would have been curative with a normal life expectancy. So it's without equivocation. Research tells us that the procedure has a 96% success rate with a 1% complication rate. So there were wonderful odds in Kevin's favour. And our family experience also bears that out, because 3 months after his death, his dad presented with the very same levels with which Kevin first presented. And we saw him have the procedure which Kevin should have enjoyed. And he is alive and well today. We have in recent times discovered that the situation was genetic, and the gene has been discovered, a thing called CDC73, and only 4 families have been identified, one in Italy, one in Ireland, one here in the UK, and one in the US. The necessary referral to an endocrinologist did not happen. The diagnosis of primary hyperparathyroidism was not made, and hypercalcemia has been allowed to progress for a further year and 10 months, by which time the calcium level was higher than any ever recorded in Cork University Hospital and was described as inconsistent with life. Kevin spent the summer of 99, as I say, in the United States on his J1 visa. On his return, he attended the GP, still complaining with bone pain, vomiting, lethargy, all of and again, still remaining in bed a lot. Blood and urine samples were taken. They were telephoned to the doctor's surgery directly from the laboratory, because, of course, they were concerned. And they were written on this post-it note by the practice nurse. And as you can see, the calcium is now at 5.73. We're gone off the Richter scale. One of those peer reviewers later trawled, he himself an endocrinologist, he trawled globally and was unable to come up with a colleague who had encountered a patient with similarly high levels of calcium. But another key point of contact failed him, because that nurse took that post-it note into the GP, offering hypercalcemia as a diagnosis, but he chose to ignore her. And he came up with his own differential diagnosis of leptospirosis based on some of the other elements in the blood test results. We later learned that he had experienced some success in diagnosing leptospirosis in a number of patients. So here you have a situation, where experience can serve you well, but it can also cause tunnel vision, and that's exactly the trap that man fell into. So when things were further compounded, because when writing the letter of referral to the hospital, he only included in the body of the letter the elements of the blood test results which supported his own diagnosis, and totally omitted the calcium reading, although he did send the post-it with the letter. But things were then further complicated in the hospital, because, as you can appreciate, you're talking about a piece of paper roughly this size. They didn't want it lost, so somebody decided to stick it to the back of the referral letter. And as a consequence, it wasn't seen until 6 weeks after Kevin's death. Not as part of any review, but when the 2 hospitals were reconciling their claims for voluntary health insurance reimbursement. So the SMAC, the standard test in that hospital, didn't include for calcium. So throughout his few days there, they were totally unaware of the high calcium levels. They didn't go deeper into doing tests. And a diagnosis of nephritis was made. Now, nephritis was a symptom. It wasn't the underlying condition. So at this time, no medical personnel seemed to appreciate how seriously ill he became as his condition deteriorated rapidly. And I recall speaking to the consultant in the hospital corridor on the Saturday before his transfer. And I was concerned about the delay in he being transferred. And I said to him, are you concerned at all about the delay? Because I have this desperate sense of urgency, that umbilical cord kicking in again. And Kevin's older brother was with me, and he said, well, what will they do differently in CUH? And he said, oh, they'll do nothing differently. Perhaps they'll take a biopsy Monday or Tuesday. Now, we were speaking on Saturday. Kevin was dead on Sunday. For Kevin, there was no Monday. For Kevin, there was no Tuesday. And again, I would say, you ignore at your peril the concerns of a mother. Despite his continuing decline, no alarm was raised. He became dehydrated, described muscle pain and neurological problems. His medical notes quote him as saying, I have crazy thoughts coming into my head. And those notes show further advancing renal failure during his stay in that hospital, as yet another point of contact failed him. Finally, he was transferred to Cork University Hospital, and it was here that we first heard concern about calcium levels. It was the first time in over 2 years that I had heard calcium mentioned in relation to Kevin. And in my ignorance, I was quite reassured, because to me as a layperson, calcium was a good thing. I didn't appreciate the havoc it can cause when it's being misrouted. The levels were now at 6.1. He, in essence, was a walking time bomb. Unfortunately, being the weekend, he was managed at registrar level. Yes, senior personnel were on call, but they weren't called, and I don't know why that did not happen. And we can only surmise. Was it a macho thing? They're not called on my watch. Or was it, well, I called some time ago in relation to another patient and wasn't received so well, so maybe I'm not going to put myself out there again. We don't know, but we should know. We should be asking the 5 whys about all these things. During Sunday, Kevin was lucid, he was very sleepy, gave a thumbs up to his father before he left the bedside. I remember it was All Ireland Sunday, and Cork were playing Meath, and he couldn't see the television, and his sister was relaying to him what was going on. He wasn't a bit pleased prior to that, because Jordan had been knocked out of the Formula One, and he was a great Jordan fan. And so, you know, things seemed good. And again, it wasn't intimated to us that his life was endangered. These high levels of calcium were not explained to us. And so his dad and brother went home to see the rest of the match, and they headed off. And just around then, the young SHO came into the room, and he checked on Kevin and then turned away. And before he reached the door of ICU, Kevin suffered a massive heart attack and died as his sister and I sat at the bedside. So we were ushered out, and I sent her rushing through the hospital corridors. And things happened so quickly, she actually caught up with her dad and her brother in the car park before they had left. So we were all brought back after a short space of time. A nurse and a doctor whom we hadn't met previously came out. And the nurse said, we have a room over here. And I looked at her and I said, it's not good you're taking us to this room. And when we got in, the doctor said, Kevin was very sick. And I said, is he gone? And he said, yes. And I didn't consult with anybody, but I do know where my next words came from, because Kevin carried a donor card. And I said, what about organ donation? And he shook his head. Kevin had been allowed to deteriorate to the point where his organs were of no use to any other human being. And that was terrible to hear. It was almost like Kevin dying twice. And I suppose at some level, I so desperately wanted some part of him to live, so donation was hugely important. But the doctor was a kindly man, and he saw the effect that was having. So he said, would you like us to inquire about his eyes? So we said yes. And his corneas were donated, and we later learned that a 60-year-old man and a 42-year-old woman now have sight. And that is Kevin's patient journey. And when we reflect on the journey, we can most certainly see the shortcomings and the failings. There was the inability to recognise the seriousness of his condition, appropriate interventions not taken, selective and incomplete transmission of information, non-receipting of vital information. I would say if you're sending information to a colleague, the least you need to be assured of is that it has arrived. There was the absence of an integrated pathway, the link between his behaviour and test results not made, his developing neurological problems ignored, and no evidence of tracking of his deteriorating condition. And you'll hear a lot about deterioration today. And when we had access to the files later we actually plotted those test results ourselves. Now, we couldn't draw any conclusions, but a small child could see that something significant was happening because numbers were changing, and there was the absence of the direct communication with the patient. There was his treatment at registrar level. There was the team dynamic. How come somebody in that team didn't speak up on behalf of Kevin and rescue him? If you're not calling, I'm calling. This patient needs rescuing. The impact of a weekend admission. And in relation to that, when my husband had surgery and I went to see the surgeon, and I actually psyched myself up because I didn't want to refer to Kevin. I wanted to keep this encounter clean. But it was he brought Kevin up and he said, I'm really sorry, Mrs. Murphy, about your son. I could have done something for him that weekend. Again, hard to hear, but again, very necessary to hear. I could have done something had I been called. And he also kind of highlighted the weekend as significant. And in fact, you know, we talk about patient-centred care. Wasn't this patient asked to accommodate the system? Please stay alive until Monday. And Kevin just could not do that. And our expectations of a tertiary training hospital certainly were not met. And then what about the response in the aftermath? What was the outcome of our interactions? Yes, there were initial humane reactions from individuals, and in particular, I remember the nurse. She was sitting at the bedside with me, she was rubbing my arm, and she was crying as freely as I was. And I was puzzled, and I said to her, but don't you see this every day? After all, we were in ICU. And she said, oh no, not that. That should never have happened. She nailed it. She said it as it was. And to my dying day, I'll be so grateful to that woman for her naked honesty. But in a very short space of time, that was replaced by a process of corporate damage limitation. And I'll bring up the post-it note again. We went to see, we had one very significant day in the hospital. We went to see various people, and we accidentally bumped into other people. And the head of department, who, if you like, had been sent to troubleshoot and deal with the family, said that even if this post-it note had been seen by his consultant colleague, it would not have meant anything to him. And I said, why? And he said, well, it's not written as we'd write it. So I said, may I see it? And then I looked at it and the light bulb went off in my head. And I said, are you saying that because it's not written in scientific notation, it wouldn't mean anything to somebody like you? And that man actually said yes. A suggestion that CAL might not mean calcium, SOD might not mean sodium, POT might not mean potassium, and they all in each other's company. And I have to say I was so angry around that. On two counts. Number one, there was an attempt to befuddle us because he thought I wouldn't know the bit about scientific notation, but my work allowed me to be aware of that. And secondly, I saw it as a very mean attempt to put the blame on the nurse. I was to come to the conclusion, oh dear, if only that silly nurse had written it properly, everything would be grand. And I was angry on her behalf. I thought it was absolutely horrible. Another suggested that the dilemma for him was an issue of loyalty to colleagues. And I can understand loyalty to colleagues. But in an instance where a patient has actually died, I think that can be ill-deserved or misplaced. The loyalty should be expressed in supporting them to step up to the bar, not in helping them to hide what has happened. So it boiled down to the fact that our confidence in any hope of ascertaining the truth through honest dialogue was shattered. We are not a litigious family, would have never dawned on going that route, but we were forced down that route to get the answers. And it also became clear that the legal system favours the defendant in matters of finance and in resources. Until the 11th hour, every effort was made to settle without admission of liability. It was a wearing down process that lacked compassion and consideration for heartbroken people. Cases like ours need to be heard in a non-adversarial environment where the focus is not on blame, but rather on acknowledging that something happened, figuring out what happened, arriving at the truth, and putting something in place to prevent recurrence. In short, learning from the tragedy. Almost 5 years later, a judge of the High Court declared, "It is very clear to me that Kevin Murphy should not have died." 2 GPs, a private consultant, a hospital consultant, and a hospital, all admitted liability, expressed their regret at Kevin's death, and sympathised with us as the family. Sadly, none of that was done in person. It was done through legal representatives. So the ownership of those apologies is somewhat fragile. Monetary compensation was never an issue for us as a family, and I became weary from trying to defend the stance of having to take a case. But you can't take a case without looking for redress. And the sum of money doesn't exist that would equate to my Kevin. Neither could we imagine any circumstances in which we'd derive benefit or pleasure. Could I buy a car? Could I do home improvements? Could I go on holiday? So what we did was, ever before we knew whether there would actually be any settlement or whether we'd still have a roof over our heads, we signed off any compensation to 2 named charities, Moher and Irish Charity, and the Make-A-Wish Foundation. There is then the other side of the coin. What about the people in healthcare who have become embroiled in an adverse event? How does healthcare treat them? Yes, as patients, we can't give permission for error, but we do understand that medicine is complex and that it's a risk-laden endeavour, and I accept unreservedly that no one intended harm to my Kevin. And I recall a chance, it was that same day that we met that awful man with the post-it note. And the SHO who had dealt with Kevin, they had gone to the same school, but they didn't know each other because of the age difference. So in the short time he was under his care, they did have quite a nice rapport. And he spotted us in the corridor and he walked across and he said, "Hello, Mr. and Mrs. Murphy. Kevin was very unlucky." Unlucky. And I was shocked. Last year of the millennium, in a first world country, in a tertiary training hospital, and somebody is using the word unlucky. So I was mad, but I wasn't mad at him. I was mad at the organisation and the colleagues, the senior colleagues, who left him with that superficial understanding of what had happened. And I think at his point in his career, he certainly deserved better. And the reason I wasn't mad at him was because I actually liked him. And the reason I liked him was because of what he did on the afternoon of Kevin's death. When news got out and Kevin's friends heard all about it, of course they came assembling to the hospital. They were sitting in the corridors, head in hands, trying to come to terms. And he passed by. And what did he do? He took off his white coat, the barrier, and he balled it up and he put it on the ground next to them and he sat with them, saying nothing. Now, to me, that was an amazing, spontaneous act of solidarity. You don't get that in any textbook. That came from deep inside that young man, the innate goodness in him. And I had this horrible feeling that nobody was recognising that in him. Certainly no one was going to nurture it. And I really did feel he deserved better than that. I also felt that he was more a comfort in the company of Kevin's friends, because wasn't he too grieving? He'd lost a patient. Chances were he was being told you have to get back up on the horse. Of course he'd have to do that. That's what your job is. But do you know, there are some horses that you need a bit of a leg up. And I had a sense this young man wasn't getting that leg up. I also think that more senior people bear quite a brunt, because again that very same day we were about to exit the lift, the door opened, and who walks in but the registrar, the man who I hadn't seen since the day of Kevin's death, and I haven't seen him since. And our eyes locked. He was obviously trying to place me, and all I said to him was, I'm Kevin Murphy's mother. Now bear in mind this is 6 weeks after Kevin's death. His face blanched, he blurted out the words, I didn't think he'd die. And he backed out of the lift and he ran away down the corridor. Now we had just come from the man with the nonsense about the post-it note, and I turned to my husband and I said, oh my God, they've abandoned us, but they've abandoned him too. Where did he go? Did he have any supports? Like, I had cause to be really angry with him, but there wasn't one bit of me wanted to see him in that condition. He didn't deserve to be in that condition. We needed to have a talk, a very difficult talk. But I'm convinced that had we been given that opportunity, we would have both been better in the aftermath. So I think there's a lot of work needs to be done around all of that. Some way of, if you like, avoiding the 5 years of trauma and uncertainty brought about by the litigation process and the awful responses which brought us down that route. So I have had some learning, and it's resulted in my little personal wish list, which says observe the guidelines, best practice, challenge each other in that regard. Following adverse outcomes, undertake the root cause analysis and include patient and family in it. Communicate effectively within the medical community and with patients. Keep the impeccable records. Listen to, respect patients, know your personal limitations, replicate what is good, and be always vigilant for opportunities to improve. Learn, disseminate the learning, practice the dialogue, the collaboration, meaningful engagement. Create a coalition of healthcare professionals, a formal coalition. It's happening in Ireland at the moment, where we're setting up a mirror image of the WHO Patients for Patient Safety. And above all, be honest and open and seize the opportunity to give some meaning to tragedy. Sir Liam Donaldson describes the 5 most dangerous words as, it could not happen here. Sure it can. It can happen anywhere to anyone, anytime. Albert Wu calls the early days in the aftermath of an adverse event the golden moment, and the opportunities are often lost in that very tight window. Through defensiveness, express loyalty to colleagues, to the organisation, and to a flawed system. The result is the confrontation, but the barriers and the causes have been identified, things like the inappropriate responses, the inaccessibility of the partnership and collaborative opportunities, the culture of medical practice, this perception of infallibility. Who can deliver 100% of the time? Not a human being. Fears relating to litigation and loss of reputation, and excluding the patient and family from the change process, and neglecting to learn from industry. And you'll hear an awful lot about that today. I have a daughter working in the medical devices industry. I have a son working in pharma, and they're not punished for error. They're punished for hiding error, because that is viewed as sabotaging the company. And I suppose that is why my very first meeting with Sir Liam Donaldson, chair of the World Alliance for Patient Safety, was so significant for me. They had identified Kevin's case as a learning tool, and I was invited to come and meet him in Whitehall. Here is this man, a knight of the realm. He walks into the room, he extends his hand and he says, hello, Margaret, I'm Liam Donaldson, sit down, talk to me. And that's exactly what we did. And he listened, and he heard, and there's a difference. He acknowledged that something happened that shouldn't have happened. He didn't offer lame excuses. And then on his fingertips, he enumerated the missed opportunities. And finally, he turned to me and he said, and you know, Margaret, any one of them would have been enough. And as he likened Kevin's patient journey to a manifestation of Jim Reason's Swiss cheese model. And I returned home to Ireland, certainly considerably healed, conscious of that acknowledgement and the validation of the patient experience. And then there's the wonderful story from the US of Dr. Rick Van Pelt and Linda Kenny. He was the anesthesiologist, known in college as Iceman, so you know the kind of individual we're talking about. But when this incident happened, he connected with a part of himself that even he didn't know existed. And
he was told, no, don't go there, don't make contact with her, despite he desperately wanting to do so. But eventually they did meet, and it was a difficult meeting between the doctor and the woman he almost killed. But he says with great relief that on that day an 800-pound gorilla got off my back. Now that's some image. Toting an 800-pound gorilla on your back 24/7, you can actually get rid of it by having a decent conversation with another human being, albeit a difficult conversation. But they went a step further. They set up together, jointly set up, an organisation called Medically Induced Trauma Support Services, which supports patient, family and clinician when things go wrong. MITSS, and you can actually, you can Google it. And I've seen them present jointly at conferences, and I tell you, it's a wonder to behold. So in summary, I suppose, healthcare can only be safely practiced in that urban environment, and we have to have that constant awareness, and attention to the prevailing safety issues. And those issues can be summarised around communication, doctor to patient, and between professionals, the style of communication. I sit on the Irish Medical Council, and it's the style of communication that causes doctors to be complained to the Medical Council. Viewing the patient holistically, family advocacy, being aware of the experience versus the tunnel vision item, patient as partner, the danger times in the patient journey, the handovers in Kevin's case are absolutely appalling, the care team itself, professionalism and integrity, and of course supports for patient and family, and supports for clinicians in the aftermath of an adverse event. So what is critical is that we do, if you like, preserve that all-important relationship of trust between doctor and patient, and initiate the powerful conversations, the dialogue. While there is no acceptable level of error will occur, and it is at that time that we are challenged to behave with the integrity to seize the opportunity and to give the meaning to tragedy. And in the name of patient safety, the onus is most certainly now on us to see that translated into safer care for them in the day, and ensuring a real sense of satisfaction for those working in healthcare who are gifted with that opportunity to serve humankind on a daily basis. Translating the aspiration into reality can sometimes be difficult. Eric Holmgren has reflected on patient safety, and he says that safety is a core value. It's not a commodity that can be counted. Safety shows itself only by the events that do not happen. So how do you count a negative? Where's the metrics for that? It's also very significant that Tulga Monday in the United States posted a blog in the New Yorker, and what he said, and I find it very precious, and it has actually changed a lot of my own views around this. He says that more than anything, what distinguishes the great from the mediocre is not so much that they fail less, it's that they rescue more. I think that's powerful, because that is all about the deteriorating patient. And that word fail, because of how people come out through medicine, top flight students, they have this absolute horror of failure. The thing they should be concentrating on is actually rescuing. At many points during his patient journey, Kevin so badly needed someone to rescue him, to just respond to him as a deteriorating patient. And my sincere wish is that as we go forward, that's, if you like, what you will operate out of. It's however equally true that the patient and family have a vital role to play in that rescue exercise, as do patient advocates in the broader scope of healthcare. So it is up to healthcare to issue the invitation, and it's up to us to accept the challenge to be critical friends in that meaning collaboration. So to conclude, isn't it a very real fact that I was present at Kevin's birth and his mother? I knew every detail of that birth. I was also present when he died. And as his mother, I needed and I deserved to know everything about the circumstances which brought that about. But over and above that, I needed to be assured that lessons would be learned, all in the hope of preventing recurrence. Because as Sir Liam Donaldson says, to err is human, to cover up is unforgivable, but to refuse to learn is inexcusable. So thank you very much.